Hi, this is Shudas, and today we are going to do volume 2 of our weekly video series on things related to sinus disease. Today I'm going to talk about the difference between a cold and a sinus infection, and during COVID this has become a very important and relevant topic. So when people ask what's the difference between a cold and a sinus infection, I think really what most people are asking me is, is this a cold that is going to get better in a day or two without me needing to do much, and it's going to have relatively mild symptoms, versus a sinus infection, which implies something more sinister that might need antibiotics or different medical therapies or more of an intervention, and has a potential for lasting longer and causing more problems. So that's actually a really, really important question. It's something I spent a lot of my research career studying, and I'm fortunate to have worked in the lab of my lab mentor was Lauren Bakelitz, who is really one of the top scientists in this area and helped me a lot and to learn a lot about the salient points about viruses and bacteria and how they interact in the body. So let's get back to that question. First, let's define what a cold is. So a cold is, what we consider a cold is a upper respiratory viral infection that typically gets better on its own with very limited symptoms. So almost all of those are rhinoviruses, which the average adult gets about 2 to 3 infections a year. Average kid, particularly infants and young children, can average about 8 or 9 of those a year. And those are typically a virus called a rhinovirus, which is a type of enterovirus, a very small virus. And those are very prevalent and have lasted for a very long time. And that typically is what we define as a cold. So rhinoviruses are very similar to coronaviruses. They are relatively small. They are transmitted through aerosols and through the air, and are very contagious. And so when you catch those, the rhinoviruses in particular bind to a cell receptor called ICAM1, but they bind very efficiently. So you can get very sick. Not very sick. You can catch a rhinovirus very easily and very quickly. So the average day from an inhalation of a virus to it actually starting to replicate in your body for a rhinovirus is only 15 minutes. So if you inhale it, it'll start to go to work in about 15 minutes, and you typically will then start developing symptoms on average in about 2 days, as soon as a day, or sometimes maybe up 3 or 4 days, but very quickly. Our body then, viruses typically don't have the RNA or DNA machinery to create an exit strategy. They just have enough DNA and RNA, which are the molecules that tell our cells how to make proteins. And so they have enough of those to make a certain amount of proteins that allow them to replicate and allow them to basically turn down the immune system. They also, which allows them to evade our immune system for a while and allow to replicate. But they also do an interesting thing. They typically upregulate another receptor on our epithelium called a cognate receptor, which causes bacteria to move from one place where it typically is okay and is helpful to our human body, and it moves to another place where our body doesn't like it. Our body typically mounts an immune response to that bacteria, and then that's how your body, the virus escapes. So for example, we might have an adenovirus that we catch, and we inhale that, and it starts to replicate, and in a few days we get sick. Then that virus will start to cause bacteria in the back of our throat. We have 3 particular types of bacteria. One is called Streptococcus pneumoniae. Another one is Haemophilus influenza, typically a non-typable, non-Haemophilus influenza. That's a unique name for it. And another bacteria called Moraxella catarrhalis. So these bacteria live in our nasopharynx, and then we get a virus that we inhale and starts to replicate in our nose and sinuses and back of our throat. And that causes those bacteria, and when you are young children, typically we have our eustachian tubes which connect the back of our throat to our ears, but in children those are very flat. So the viruses cause bacteria to move from our back of our throat to our ears, where then in our ears our body recognizes this bacteria shouldn't be there and starts to make fluid, and we get an ear infection, and it starts making children scream, and then by screaming you aerosolize this virus, which allows the virus to escape. In adults, our eustachian tubes are not as flat anymore. They've kind of sunken. So in adults, when we get a cold, a virus typically causes those same bacteria to also migrate into our sinus cavities. And then in our sinuses, our body detects these bacteria that shouldn't belong. It creates a lot of mucus, and we blow our nose, we sneeze, we get mucus all over our hands, and it gets all over the air and on surfaces, and the virus is able to escape that way. So an important part of another distinction we often make that we're trying to get to is this illness caused by a virus, or is it caused by a bacteria? With the implication being, if it's a virus, it's going to typically go away on its own, or there's not much we can do about it. And to giving somebody an antibiotic, which is almost always an antibacterial agent, like penicillin or amoxicillin or augmentin or Bactrim, those types of medicines kill bacteria. So giving those in the setting of a viral infection is thought to be unhelpful and potentially even harmful from a medical setting. Now, on the other hand, in the simplistic way of looking at things, we say that about 15% of colds or infections go on to become sinus infections, which often implies, that this is now a longer bacterial infection, and those may need antibiotics. So it's tough for your primary care doctor or healthcare provider to know which is going to be the 85% that resolve uneventfully versus which is the 15% that might need an antibiotic or some future treatment. So let's talk a little bit deeper about that and what's actually happening. So in reality, all viral infections, they just do not, like we said, do not have a lot of genetic code to have an escape plan out of our body. They have enough of a genetic code to bind to our cells, create a fusion event where the virus fuses with our cells. They get into our cells, start to replicate, and then they need some help to get out of the body now. And so the way they do that is, like we said, they trick our body into having our natural bacteria move from one area to another area. So in reality, most viral infections then are a combination of both a viral replication event that our body doesn't want and a bacterial migration event that our body doesn't want. So we have bacteria moving and growing from one area into another area of our body that we don't like. So the 85% that we typically quote as just a viral infection, those are really the situation where the virus infects our body, causes the bacteria to move. Our body mounts a quick immune response, an effective immune response against that bacteria, and basically wipe out the virus and the bacteria very quickly. and then get us back to our normal state. But in the act of wiping out that bacteria, we were coughing, made a lot of mucus, runny nose, rhinorrhea, and we then created a situation where the virus can spread. So that happens in almost all situations. Coronavirus is interesting, and rhinoviruses are also not necessarily cause a huge amount of bacterial disruption. That's why they can be so mild, in that some viruses replicate in our body and then just spread very quietly into our lower airways, where when we aerosolize our mucus by talking or screaming a lot, the viruses can then get airborne that way. And then those viruses don't actually even use a lot of bacterial migration to assist in their cycle. So rhinoviruses and coronaviruses don't really have a huge amount of secondary bacterial problems, and that's why we're not seeing a lot of bacterial issues per se with those viruses. But the typical viruses that a lot of viruses that we see do use this bacterial issue. So in the 85%, it's because our body cleared the bacteria very quickly. So that's why, for example, you can't use yellow or green mucus as an indicator of if you have a viral or bacterial infection, because the yellow and green mucus, those are products of our neutrophils that are being produced, but they are in response to an effective immune response that's clearing the bacteria. So in those cases, we're not going to need antibiotics. So what are the 15% that we do call a sinus infection or a bacterial infection, or something that, where people get sicker? Those patients, for whatever reason, have a situation where the bacteria, when it spreads from our nasopharynx into a different area, like our ears or our sinus cavities, for whatever reason, those bacteria are now able to set up shop in those areas. And they do this by the bacteria, first of all, they were happy living in our nasopharynx, and they're not so excited about being tricked into moving into an area where our immune system is going to detect them. But when they do, they tend to form, and they're under attack. The bacteria in their natural cycle tend to form these structures called biofilms. And what they do is they secrete their DNA outside of their cells, and so they secrete a lot of extracellular DNA, and it creates like a fortress of sticky molecules that are really hard to penetrate, and it creates kind of this cobweb that bacteria can then grow. And they don't really grow, they just kind of sit and wait out and try to survive until there's a more opportune time where they can spread and grow. So these bacteria, while they're being attacked and our immune system is trying to eradicate them, they go into a defensive structure called a bacterial biofilm. And 15% of the time, these biofilms somehow are able to persist. And so they might persist by staying in a sinus, and there could be a sinus, for example, that drains very poorly, that has like some cellular structures, like what we call in sinus surgery Haller cells, or different anatomic obstructions like a septal deviation or whatnot, where the mucus doesn't drain well, and so our body isn't able to wash out the bacteria that kind of get into these tough areas, and so those biofilms are able to start to take hold, and then those patients now have a persistent infection that's going to last a lot longer. And so there are a lot of patients I see that are often frustrated when they go to a doctor or to an urgent care, because they're like, shoo, every time I get a viral infection, I know if I don't get antibiotics, it's going to blossom into a bad situation right here in my forehead, or it's going to happen a lot. Those are, the patients are often correct. They kind of know that if they get a viral infection and they feel certain symptoms, that they have a history that this is going to progress into a bacterial infection that persists and stays. So those 15% of people are people we want to give antibacterial agents or antibiotics, and we want to give them as quickly as possible if we knew that they were going to get sick, and if they were going to get a bacterial situation, and we want to give it to them as thoroughly as possible because we want to wipe out that bacterial colonization completely so that we don't get into a situation where we're partially treating that biofilm, where we beat it down but it's still a portion of it is in your sinuses and now it's coming back, and then we're beating it down and coming back. By doing this, we put your body through a lot of cycles of killing a lot of good bacteria, particularly in your GI system and all the other good bacteria that are in your sinuses and in your body that protect us from getting bad bacteria from setting up shop. But these bacteria are also very, very efficient at sharing their own DNA. And so if any of these bacteria mutate an ability to pump out penicillin, for example, out of their cell wall, they'll take that resistance gene and put it on a plasmid, which is similar to a bacterial virus, and they will then send it to all of their neighbors, and so rapidly all the bacteria in your sinuses can then become resistant to whatever antibiotic we tried to treat you with. So those are kind of the take-home points. That basically, in summary, most viruses cause bacteria to move in your body, and therefore you will have a little bit of a bacterial reaction. And so almost all viral infections will have some yellow or green mucus, and those should get better. But about 15% of them, they're not getting better. And if that's happening to you, and that's the time you want to get treated with antibiotics. So there was a great study done. There's a great virologist at University of Virginia long before I was there, but who I read a lot of his work. His name is Jack Gwaltney, but he really modeled a classic viral infection very well. So with most of the rhinoviruses and the adenoviruses, the common cold viruses, coronaviruses cause mostly common cold outside of COVID-19 and its variants. They typically start with a fever on kind of day one and maybe day two of when you start developing an immune reaction to the virus in your body, and then some chills often, and a runny nose, sneezing within the first week. And then in the second week, if things are going away, the fever goes away very quickly after day one or day two. Runny nose and sneezing kind of go away, and congestion go away after about a week. And then cough and kind of your ear popping, or what we call eustachian tube dysfunction. That is the slowest thing to go away, and those typically go away in about 2 weeks. So if that progression is happening for you, then you probably are just having a viral infection that is resolving uneventfully, and you're going to be okay. You typically feel bad for about a day or two, and then the rest, you're not perfect, but the symptoms are very mild, and it typically still takes about 7 to 14 days for you to get completely back to normal. Now, and so for those, a treatment of a cold, and one of these talks I'm going to go secretly to a drugstore and kind of go through all the medicines and which ones I like and I don't like, and how they help and which ones are good for certain situations. But typically for a cold, the best things I like to tell my patients are really hot, steamy showers, and inhale a lot of steam that thins your mucus and helps your body get rid of a lot of bacteria, for example, in your sinuses and your eustachian tubes, and helps things flow. Also, rhinovirus is adapted to replicate a little bit better in colder temperatures, so they do better in winter months. So we often do better under heated conditions or in the summer in preventing that replication. So hot steamy showers are very, very helpful. Gargling with salt water is helpful. Tylenol only works in our brain, and so it reduces pain and kind of suffering in a specific area in our brain that reduces pain. So it's very helpful in the sense that it only affects a portion of our brain, but it doesn't really reduce inflammation throughout our body. And now the one area Tylenol is not helpful is it consumes a molecule called N-acetylcysteine in its metabolism, and so our liver also needs that molecule to function well. So if you have liver problems, or you've had hepatitis, or you have poor liver function, or if you're an alcoholic, or if you've drank a lot, our alcohol also requires that similar molecule. So drinking and Tylenol are bad mixtures, Tylenol is not good for people with liver problems, but otherwise Tylenol is a great drug for people who have a cold. And then ibuprofen and aspirin, those are also good drugs. Aspirin not for children because it can cause a problem with a viral infection called Reye syndrome, so we don't like aspirin use in children, but ibuprofen is a great medicine for children. And alternating the two, Tylenol and ibuprofen, acetaminophen and ibuprofen alternating is often a great mixture, and things will typically resolve. Now, if after about a day or two, if you're having really localized pressure in a particular area, or your symptoms become what we call unilateral, where they're more focused on one side or the other, or you get another fever, what we call a double fever, that doesn't occur in the day one or day two. You had a fever that went up and then goes down and now is going back up. Those are all signs that you might be developing a localized bacterial issue, especially if the yellow and green start to really increase or thicken. And so all of those signs should be signs that you should consider trying to go to the doctor to get antibiotics. And if those do happen, you want to go quicker than later, and you want to make sure you take all of your antibiotics until your symptoms are fully gone, because that will ensure that you won't get kind of a recurrence of a problem where things got well when I was on antibiotics, but then right when I stopped them, they came back. That's and often a problem for people who have chronic sinusitis, which we'll talk about at another time. But those are really the kinds of symptoms that you should be looking to see if you have what is a sinus infection and need something. So something localized to one particular area, particularly one side stronger than the other, or if things at day 3 or day 4 of your infection ever start to get worse, a double worsening. If you ever get worse after you've initially been sick, day 1 and day 2 is obviously terrible when you have a cold, but if you then get worse again, that's a sign that you should potentially go to a doctor to seek out often antibiotics. So I hope that was helpful in discussing the differences between the two. That's obviously a lot more complicated than what I just tried to say, and if there are things that I said wrong, please send us some messages and I'll fix those. But otherwise, I hope this was helpful, and we look forward to your comments, and if you need further information, please contact our clinic. All right, thanks so much.